Hello, good evening. Well, thank you very much for attending today's International Symposium. Is health distributed equally, global aging, healthy aging? My name is Masako Toriya from Extending Healthy Life Expectancy Project, Keio Global Research Institute, and I am hosting this symposium. Now, the symposium starts with opening remarks by Professor Masato Yasui, School of Medicine, Keio University, and the Research Project Keio 2040 General Leader. Please start.
My name is Masato Yasui, Professor of Pharmacology, School of Medicine at Keio University, and leader of this Keio 2040 project. Welcome and thank you for joining us in today's KGRI Symposium, entitled is Health Distributed Equally, Global Aging, Healthy Aging. Before we formally begin with the symposium, allow me to say a few words about KGRI and its project, as well as on the content of today's symposium. KGRI was established in 2016 as a base to further promote the globalization at Keio University. Its purpose is to continue the advancement of multidisciplinary research activities and to broadly disseminate the outcomes globally. As part of this mission, the research project Keio 2040 was established in 2021, fundamentally on the three pillars of research, namely longevity, security, and creativity. Among various social problems, I believe that the 2040 problem is one of the most serious and pivotal. Japan's population of elderly persons is projected to reach around 40 million by 2040. Japan is destined to become a super-aged society unlike any other in the world, due to the increasing seriousness of various social challenges, such as a rapid decrease in the working population, increases in the numbers of people requiring long-term care, and rise in social security costs. It is predicted that Japanese society will no longer be able to sustain itself in its current configuration. The world is watching Japan to see how the country will overcome this crisis as a front runner in facing a super-aged society. The research project Keio 2040 is initiative to maintain the independence and self-respect of individuals in Japan as a whole, as well as to formulate a healthy and robust society. Independence and self-respect is the founding spirit of Keio University and signifies the maintenance of one's personal dignity and acting on one's own judgment with the responsibility this entails in all matters. The research project Keio 2040 has three sub-projects. The Extending Health Life Expectancy Project, Revolutionary and Interdisciplinary Soft Matter Integration Project, and Platforms and 2040 Problem Project. Today's symposium is part of the Extending Health Life Expectancy Project and aims to develop international multidisciplinary discussions on aging and health life expectancy. Today, Professor Katsunori Kondo from Center for Preventive Medical Science, Chiba University, will give a lecture on the social health gap and social determinants of health and talk about what we can do to reduce health gap at the community and national levels. Professor Kondo is the author of the book Health Gap Society, What Undermines Mind and Health, second edition, which was published in June this year. In addition, Dr. Daniel Holman from the Health Lifespan Institute at the University of Sheffield will join us as a commentator to expand on the topic and present additional data from various research activities he has been involved in. We are thrilled to learn about social health gap that may be under-recognized, especially in Japanese context, yet crucial event when we think about increasing the length and quality of healthy aging. Finally, my gratitude for you joining us today. Thank you.
Now, we will have two parts of lecture from Professor Katsunori Kondo, who is a professor at Center for Preventive Medical Sciences, Chiba University, head of Department of Gerontological Evaluation, Center for Gerontology and Social Science, National Center for Geriatrics and Gerontology, and the president of Japan Agency for Gerontological Evaluation Study. Dr. Kondo is a very famous social epidemiologist. He has been conducting research for many years on revealing the significance of social determinants of health that cause health inequalities. In 2020, he received an award from the Japanese Medical Association for his excellent study on social epidemiology aimed at reducing health inequalities. And his research has been translated into municipal and central government policies. It's a great honor to welcome such a distinguished researcher, Dr. Kondo, to this symposium. Thank you. Professor Kondo, please start your presentation.
Can you hear me?
Yes, I can hear you.
Thank you very much for inviting me to this international symposium. It's my great honor and pleasure to make my presentation here and sharing our knowledge and experience with you. Then I will show you my top page of slide. Can you see slide?
Yes.
Okay.
It's okay.
Okay. Today, I will make a presentation concerning health inequality. Is health distributed equally? I will talk about this topic and the mechanism of health gap and our trial to reduce health inequality. This is the contents of half of my presentation. The first part of my talk is focused on is health distributed equally and why, and the process of generating health gap. And the third part of the first part is concerning social determinants of health. I am a principal investigator of Japan Gerontological Evaluation Study. The acronym of those are JAGES or JAGES. This research initiative is one of the few population-based gerontological survey in Japan, which is established in 1999. In this initiative, we focused on social determinants of health, SDH, and social environment, including social capital. In 2010, more than 100,000 older people across 31 municipalities from northern part and southern part of Japan responded to our survey. And we repeated the survey 2013 and 16 and 19. And more than 50 municipalities participated in this collaborated survey, and the response rate is roughly 70%. And we published the results of the survey in this book. We found significant health inequality in Japan based on our research project named JAGES. This is one example of our results. This slide shows relationship between equivalent income and depression. Vertical axis means prevalence of depression measured by geriatric depression scale, GDS. And horizontal axis refer equivalent income, $1,000,000 per year. And we divided into 4 age group, and generally older shows higher prevalence of depression. So please look at the same color. Same color means same age strata. And you can see the huge health gap between right-hand side richer people and left-hand side poorer people. We found more than 5 times health gap between income level. This is one example. But this kind of cross-sectional study, a survey at one time, cannot distinguish cause and results. Reverse causation is included in this kind of cross-sectional study. To eliminate such a reverse causation in this context, more depressed people lose health, then lost job, then their income decreased. So we try to conduct longitudinal study, and we followed healthy older people more than roughly 30,000 people for 4 years. And vertical axis means mortality rate and incidence of functional decline. And the horizontal line means left-hand side is the figure for male, and right-hand side refer female. And the left side bar means lower income people, and right-hand side shows higher income people. And you can see lower income people, poorer people shows higher mortality and higher incidence of functional decline. So it means that it is not only reverse causation, but cause is income, and the results are mortality and incidence of functional decline. And our next next challenge was to visualize such health disparities. We met urban health equity assessment and response tool developed by WHO Kobe Center in 2011. Urban Health is a management tool for all ages and developed for all countries, including low and middle income countries. We have data developed country, Japan, and higher income countries, but only for older population. Then we developed JAGES heart using the JAGES data. This is one example of JAGES heart. We divided, we sort the figures from many municipalities, from low prevalence to higher prevalence. You can see a bar chart on the bottom of this slide. And we divided into 5 groups, and we changed the color. So, for example, this is a prevalence of depression. That is distributed from roughly 15% to more than 30%. So there are twice disparities are observed. And you can see green tiles or the green bars means lowest group of prevalence of depression. And red color means municipality with higher prevalence of depression. So you can easily understand which municipality shows higher or lower prevalence of depression. And the next function of JAGES heart is produce a protogram like this. So in this graph or a figure, you can easily understand the relationship between 2 variables. For example, this protogram have lower horizontal axis refer to participation rate in sports club in the community, and vertical axis refer the percentage of experiences of falls during the previous year. So you can see the relatively strong relationship between these 2 variables. So you can understand participation in sports clubs seems to be helpful for preventing falls. So we can find out these kind of the correlating factors based on these very simple analysis. So I will show you another example. Recent days, the frailty is a hot topic in Japan or Asian countries. The frailty is the status between healthy status and disabled status. And people who have frailty have a risk to drop down into disabled status, and simultaneously they have a possibility recover to healthy status. So the characteristic of frailty is preventable status, and it is reversible status. And when we compare the prevalence of frailty between 64 municipalities, we found that the lowest prevalence was only 5%, and the highest maximum prevalence is more than 30%. So it means the prevalence of frailty is differ between municipalities more than 2.6 times. And please aware of the age group used in this analysis. We limited to only those aged 65 to 74. So the aging is not the reason why such huge health disparity in prevalence of frailty observed. And in the right-hand side, you can see the prevalence of frailty is strongly correlated with the percentage of participation in sports and hobby groups in the community. But this kind of cross-sectional study include reverse causation. So social capital, such as social participation, may affect good health. However, the healthier people are the more likely participated in community organization. So we have to omit or reduce this kind of reverse causation. So this is my framework explaining health from socioeconomic factors in left-hand side in the slide to health, the pathway of from SDH to health. Community level factors influenced on individual level factors, and finally health. And as individual level factors, social class, social support and social network, and psychological factor, psychosocial factors, intermediate factors, and in the last stage, biobehavioral factors are located in the last stage. And we confirmed the longitudinal relationship between social participation and mortality or functional decline. The horizontal axis shows the number of types of participated organization. So left-hand side shows the results of those without participation, and one kind, two kinds, three or more kinds organization participated by older people. And we found that the older people who participated in more organization in the community shows lower the incidence of mortality or functional decline. So it means that participation into the local organization was good for your health. And this is another result of our analysis. We wonder, exercise or participated in exercise group is the same or differ the effect for prevention of functional decline. And we found that there are different. Light green means the older people participated in sports group, and dark green means non-participants into community sports or exercise group, but exercise alone. So you can find dark green bar is higher than light green. It means that exercise alone is not so effective for prevent functional decline compared to exercise with member of sports group. So it means that not only exercise, but participated in group have some preventive effect for functional decline. And another result suggests social connection is very important for prevent developing dementia. Right-hand side group with higher point of social connection have a suppose support among family member and interacting with friends and participating in community group activities and working. And older people who shows higher social connections shows lower developing incidence of dementia. So social connection have a preventive effect for developing, prevent developing dementia. And this slide shows the results of our analysis. And we found many longitudinal relationship between from social determinants of health to right-hand side health outcome. And we published 3 English books presenting these results. So many social determinants of health are observed across the world. Not only individual lifestyle factors, but also social and community network and other factors such as education, work environment, and unemployment. Such a socioeconomic and cultural environmental conditions influenced on people's health. Definition of social epidemiology is defined as the branch of epidemiology that studies the social distribution and social determinants of health. And that is both specific feature of and pathways by which societal conditions affect health. So this is the first part of my talk concerning on social determinants of health and social gap in the Japanese society. Thank you for your attention.
Thank you, Professor Kondo. It was interesting that among many social determinants of health, especially social relationships and social connectedness have a strong impact on health, not only psychological health, but also physical health. Also, the diagram of many health determinants identified in JAGES especially interested me. Each element intricately relates to each other. It was very interesting. Well, today we have Dr. Daniel Horman as a discussion commentator. Dr. Horman is a lecturer of Healthy Lifespan Institute, Department of Sociological Studies, the University of Sheffield. Dr. Horman participated in the last KGRI Symposium and gave a presentation on social determinants of health, health inequalities, and health policies for healthy aging. Now, I would like to have some comments from Dr. Horman. Dr. Horman, please.
Thank you very much. First of all, thank you for the invitation to join the symposium today. And thank you, Professor Kondo, for your really interesting presentation. I think you've shown us convincing evidence that health is not equally distributed in Japan. So we've seen evidence of income inequalities in depression, mortality, and functional decline, and municipal inequalities in depression, mortality, and functional decline. So I think this shows that where you live and how much money you have has an obvious impact on your health and on your healthy aging. A crucial message I think that you presented here is that early onset age-related decline and morbidity is to some extent preventable. And you presented a range of evidence that social determinants of health are key to why we see such inequalities. So if you participate in sports or hobby groups, and if you have rich social connections, then you're more likely to be healthier. So I'm a strong supporter of these messages. But I'd like to offer my own reflections as a UK-based researcher of health inequalities and social determinants. So the first of these reflections is that the title of your book is Health Inequalities in Japan. And this immediately makes me think of the role of international comparative research. And I wonder to what extent the health inequalities you uncover are distinct to the Japanese context, and where they differ, what this tells us about the configuration of social determinants in Japan versus other countries like the UK. So I'm a firm believer in the value of comparative policy approaches which emphasize opportunities for mutual learning in terms of what works well in particular contexts and whether we're able to apply that in different contexts. Lots of the evidence that you presented comes from the JAGES data set. And as you know, there are many other data sets of older cohorts around the world which offer rich opportunities for that kind of international comparative research. My second reflection is on how these inequalities might have changed or are changing over time, whether they're widening or whether they're staying the same or indeed reducing. So in the UK context, we've seen quite a widening of health inequalities. So life expectancy has stalled and declined in some cases, and that's especially been for lower socioeconomic status women. In the UK context, this is likely due to decades of right-wing governments who have had lower rates of welfare spending, austerity policies, lower investment in social and community services, etc. Just those determinants that you've shown that are important for healthy aging. So this might be a lesson, at least for Japan, for what to avoid in terms of tackling health inequalities. And then tied in with this point, as you know, there's increasing attention to the commercial determinants of health and the role of unhealthy industries and commercial activities and the role of commercial actors in promoting health damaging products. My final reflection is on the role of participation in sports, hobbies, and social connections as determinants of health. And what I'm particularly interested in here is whether in Japan, and I guess generally, there's a relationship between socioeconomic background and these variables. So are lower income groups likely to have lower social capital? Are they likely to participate in different types of sports and hobbies? And what implications does this have for health and well-being? So in the UK, at least, there's a stereotype that working class, lower income people have high levels of bonding social capital. That is, they have strong community networks and ties, and middle class people have high levels of bridging social capital. That is, they're better at networking across communities and across groups, and they have the right sort of social connections to achieve success. So I'm interested in the role of these different aspects of social capital and their relations to socioeconomic position, and how this may impact health and health inequalities. Thank you.
Thank you. Thank you very much, Dr. Holman. He suggested the possibility of international comparative research. I think it's a very important idea. And I also think it would be very interesting to see the relationship between health inequality, economic inequality, and social capital inequalities, as he suggested. And thank you. In his comments, Dr. Holman asked Dr. Kondo some questions which will be answered later in the discussion, okay? And now we will move on to the second part of the lecture from Professor Kondo. Professor Kondo, please start your presentation.
Okay. Then I will share my slide, the second part of my talk. Can you see my slide?
Yes, I can see.
And the second half of my talk focused on what can we do to reduce health gap and build a health aging society. And Japanese government published new health policy in 2012, Health Japan 21, which started 2013 and 10 years plan. This is a schema of the Health Japan 21. The top number one present the basic direction of this health policy of Japan. The Ministry of Health, Labor and Welfare add new concept, reduce health inequality into the top priority as basic direction of Health Japan 21. And the strategy to reduce health inequality was to improve the quality of the social environment. So it is because the first Health Japan 21 from 2000 to 2010 focused on healthy lifestyle. The left-hand half of this schema, but such effort did not succeed. Then the ministry added right-hand half of this schema. So focus on social environment and to reduce health inequalities. And WHO published a report concerning on healthy aging, and they emphasize the importance of environments. And each older people have intrinsic capacity, the capacity of their own, but function or functional ability is determined by not only intrinsic capacity, but environments. So environments are determinants of functional abilities. One typical topic or concepts of social environment is social capital. The famous researcher Putnam at Harvard University defined social capital as features of social organization, such as trust, norms, and networks that can improve the efficiency of society by facilitating coordinated actions. So, there are some discussions. The social capital have two levels or three levels, and this which is individual level and family level or community level or state level. So there are several levels. So as I talked before, the social participation is very a strong factor related to health. So, and social participation is a one factor, related factor of social capital. So based on social capital theory, we conducted an intervention trial tackling inequality in social participation and active or healthy aging. And the purpose of this trial is to evaluate the new program developed for healthy aging and tackling health inequality, particularly in social participation. And we organize the volunteers, mainly older people, and we ask them, please develop new social activities consist of enjoyable social programs, such as ping pong and games and making short poem and physical exercise. And this is the key concepts of the program. It is based on population strategies, intervene in social environment by developing new social activity programs. And not only a few sites located in the center of the town, but multi-site programs. By that, all the people living in anywhere in the town can easily come to the site on foot, and managed by volunteers, not professionals, because multi-sites activity needs many staff members. And this is Taketio town, and Taketio government organize volunteers and support them through providing public space, financial assistance, and advertising to the citizens by a public relations paper published by the town. And not only physical exercise, but also a variety of enjoyable social programs are provided by volunteers. And this is a theory of or logic models of preventive program for healthy aging. So left-hand side is start, and right-hand side is results. And people participated in the program have an opportunity to physical or psychological activities, such as increase activities, opportunities to get out, and increase enjoyment, intellectual activities, and self-efficacy. And these kind of activities develop or maintain physical functions or cognitive psychological functions. And these changes bring healthy aging for individual level, and for community level is yellow part, the bottom of this slide. Social network or developed, and the facilitate volunteer organization in the community, and these efforts makes a social function of community developed. So this effort makes social capital richer in the community. So, so we organized volunteers for this program. So following our intervention, the number of volunteers increased rapidly up to 9-fold. And this is trends of number of participants and events. And you can see a rapid increase the number of participants and events. And we conduct follow-up survey to residents in the Takateo town. And we identified more than 300 older people who participated in this program. And these 300 participants replied that they feel happier compared to previous 1 year. So it was before introducing this program. And they also responded, they increased the number of friends compared with 1 year. So it means that this new program have the effect of psychosocial interaction. And this is another result from our survey. We compared between participants and non-participants in the new programs. And the left-hand side data from males and right-hand figures from female. And the vertical axis is rate of new participants for senior club, volunteer club, and sports club. And orange bar means participants, and blue bar means non-participants. Roughly 5 to 10% of non-participants started participation into senior club, volunteer group, sports club compared to previous year. And compared to blue bar, participants, orange bar, shows twice or fifth higher rate. More people started participated into such groups in the community. So these kind of activities have an effect which make older people's life more active. So, for example, some people participated in these activities, invited to another activities, such as volunteer group or sports groups. So the incidence of participation into this activity was not so high, roughly 1 time or twice per month. But they also participated in other group in the community. So their lifestyle changed, more active. So as a whole, participants shows about a half instance of functional decline compared to non-participants. So very strong preventable effect are revealed by this intervention study. And also instance of dementia reduced roughly 30% compared to not participants. And from the viewpoint of health disparity, the participation rate into the new program is completely opposite compared to health checkup or sport, other community activities. Higher educated people tend to attend health checkup or sports club. Compared to that, the lower educated people or economically the poorer people shows higher participant rate into the new program. We were very surprised. It might the reason to attend a fitness club or golf club need very expensive fees or membership. But this new program is very cheap, and the participants not need car because they can attend or go to the activity site by on foot. So for people who easily participated in this new program in the community. And the town, following our results, decided to add this program to their general plan. So number of this activity site increased until 14. Now it is same as nursery school. So this slide is summary of program for healthy aging. The new intervention program showed more favorable results. More people participated in the new PHA compared to the previous one. And we found the new PHA can reduce the rate of functional decline of participants. It might be possible to narrow inequality in functional decline among older people by the new PHA, because we got more participants from lower socioeconomic status compared with the previous program. And this is results of our systematic review written by Dickens. He summarized what kind of intervention targeting social isolation is effective. They reported group-based intervention and participatory activities, and having a theoretical basis, and not providing support or home visit or internet training, and compared to those providing activities is more effective. and not targeted intervention, no explicit targeting type intervention was more effective. And our new program conducted in Taketoyo Town have these characteristics. I would like to move to the national level policy measures to reduce health disparities. We analyzed association between childhood socioeconomic status and fruit and vegetable intake among older people. And we divided into 3 groups of childhood socioeconomic status. And we divided into 2 groups for frequency of current vegetable and fruit intake. And we found that prevalence of lower frequency of fruit and vegetable intake, less than dairy, is more prevalent in lower socioeconomic status at childhood aged 15. And we also found that such disparity is significant in older, but such health disparity is not observed among younger, older people. And we found that school lunch program introduced after World War II, and they had a strong impact on height and weight of the children. The bottom was 1946, just after World War II. And school lunch program aimed the effect, improving knowledge on nutrition, dietary behavior of family member. And we found that older do not have experience to have a school lunch program. And younger, older exposed school lunch program after World War II. So it might be the effect of school lunch program of these kind of disparity of healthy lifestyle, eat habit in older age. So this is one example. WHO shows this framework from many policies could influence on health inequality. Right-hand side is health equity or well-being, and left-hand side is socio-economic and political contexts, and many social policies or public policies can influence on the health through many pathways. So, for example, in Japan, Health Japan 21 introduced 2012, and following that, a role on the promotion of policy on child poverty introduced, and role for supporting independence of the poor introduced, and basic role for suicide prevention revision devised in 2016. And this is the results of 10 years Health Japan second term. The bottom line with dot means 令和元年、そうか、2012 and blue dotted line was 2016 and the red dotted line 2000 no そうかthe bottom line referred 2010 and blue dotted line 2013 and the red dotted line 2016 and the top dotted line referred 2018. And please show, look at the left-hand side, males. The slope is steep in 2010, and the slope gradually close to horizontal compared to 2010, and 2018's line is more horizontal. And this line consists of 47 dots. So it is prefecture. And the vertical line means longevity. So if the slope is steep, the health disparity in longevity, life longevity is wider. So it means that health gap in the male significantly reduced during these 10 years. For female, such a significant change is not observed, but male shows significant change. So it means that policy, when we tried many policy to reduce health disparities, it can be happen, reduce the health disparity. This is Japanese experience in this decade. So this is the end of my lecture. Thank you very much for your attention.
Thank you, Professor Kondo. I was especially impressed that the school lunch program can have such a long-term impact on socioeconomic status in elders. I think we should be proud of the Japanese school lunch system with a good nutritional balance. Now, I would like to have comments from Dr. Horman on the Professor Kondo's lecture. Dr. Horman, can we have your comments?
Thank you very much. And thanks again, Professor Kondo, for the second half of your talk. I was particularly interested in the intervention you described to tackle inequality in social participation and active aging. And it seems to me to be a particularly valuable approach because of how low cost and accessible it is to a wide range of people. So you talked about the intervention being multi-site, run by volunteers and involving low cost activities such as games, exercising and chatting. And the outcomes of the program are also very impressive and I think powerful from a healthy aging perspective. So I'd just like to share my own experiences of working on an intervention that had many commonalities. The program that I worked on involved bringing together groups who spent time exercising and chatting, and it was also led by volunteers. It was a multi-site program, so that it was accessible. So there were many similarities between the programs, but what is really interesting is that the program that I worked on was not designed to increase social participation or address inequalities, but it was about creating type 2 diabetes peer support groups. So these were groups where people would come together, they would meet to talk about managing their diabetes, share healthy recipes, they would do exercises and provide social and emotional support. And so the intention with that was not to create social capital because the intervention was led by medics and they were concerned with reducing HbA1c more than anything else, so blood sugar levels basically. But in fact, it did create social capital, and that's what people reported as one of the main things that they enjoyed with the program. But one of the challenges that we had, and I think a contrast to your experience, was that people who took part in the program tended to be from higher socioeconomic backgrounds. And this was especially the case for the volunteer peer support facilitators. So they led the groups, they volunteered to lead the groups. So these were mostly retired teachers, doctors, nurses, other types of professionals who were confident enough to lead the groups because that's what they had done for their whole careers. And in some ways this was good because it meant that the groups were quite well run and managed. But in other senses, this posed a challenge for inequality because working class people tend to feel more comfortable and included if other working class people are leading the groups to create that sort of sense of commonality. So in relation to my earlier point around mutual learning between countries and contexts, I'm really interested in how the program for healthy aging that you described, Professor Kondo, was able to include large numbers of lower SES participants. Maybe it's because the program was different in certain respects. Maybe it's because social class is different in Japan. But it might be there are certain features that you deliberately designed to have that sort of wide participation. I just want to offer one more brief reflection, and that's around the graph that you showed. So I was similarly impressed with the rapid increase in height and weight after World War II as a result of that program. It's quite remarkable, and I think it really emphasizes the importance of what is commonly referred to as the long arm of childhood. In other words, what happens to us early in life has a lifelong influence on our health and well-being. And the previous program you presented, I think, showed the importance of intervention in later life and how that can have powerful effects. But the graph on height and weight and that nutrition program and the paper that you showed on childhood SES and fruit and vegetable intake, I think shows how childhood really sets the seed for later life healthy aging. And it's never too late to intervene, but at the same time, it seems to me that we should put particular emphasis on early life conditions because these experiences, set in motion a lifetime of advantage or disadvantage, and therefore a lifetime of either healthy or unhealthy aging. Thank you.
Thank you, Dr. Horman. I'm sure we'll have a lively discussion about the programs for healthy aging in the following session. Now it's time for the discussion. One of our Extending Healthy Life Expectancy project members, Dr. Kazumi Ota, will join. Dr. Ota is a clinical psychologist specialized in geriatric population. Dr. Ota, please start. Oh, Dr. Ota?
Yes, thank you.
Okay.
Can you hear me?
Yes,
Thank you, sorry. Okay, thank you, Dr. Taria, for the introduction. And thank you very much for Professor Kondo and Dr. Holman for the very interesting lectures and comments. And I'm Kazumi Ota. I was working in a hospital as a clinical psychologist for over 10 years, mainly with elders with dementia or mild cognitive impairment. And part of my job was to give neuropsychological examinations to assess their cognitive abilities. And from my experience, I have realized that those people who come to see us professionals in early stage of cognitive decline are likely the ones who have long educational attainment and or high socioeconomic status. And back then, I did not know the term health gap or health inequalities, but from today's lectures, now I understand this is how health gap can be created, because if the cognitive impairment is detected in early stage, the treatment can be more effective than advanced cognitive impairment. And there are many things we can do to prevent or slow down further cognitive decline. And as a result, the development of dementia may be delayed. So these people who come to the hospital in early stage can benefit from the treatment. And maybe they can be able to sustain healthier condition. So now I understand this is one of the examples of how health gap can occur. And when I was working in the hospital, I was always thinking that, well, those people who really need to be reached out are those who do not come or cannot come to the hospital to see the professionals. So in that sense, the community intervention or community group activities that Professor Kondo described, maybe it seems to be easier for people to join because it has it's more accessible physically and psychologically. And physically because it's multi-sided, like explained earlier, and also psychologically because it's run by volunteers and it's open for people in the community. So maybe it's, for many people, it's less intimidating than going to a big hospital to see the specialist. So yes, and it's fascinating that this community activity has positive impact on participants' cognitive abilities as well as many other aspects. So before I give you some comments or questions, I would like to start with the questions from Dr. Holman. And Dr. Holman posed some questions in his comments. The first question was, to what extent the health inequalities are distinct to Japan and where they differ, what this tells us about the configuration of social determinants in Japan in comparison to other countries. So Professor Kondo, do you have, can you answer this question?
So, because today's audience, most of today's audience is Japanese native, then I will change the language to Japanese.
So in Japan, we are yet to understand, or they have these kind of researches. It's very little in Japan compared to Western countries. So we do not quite understand where and how many health disparities exist in Japan. We do not know as the entire country's situation. And when it comes to income inequalities, Gini factor, Japan used to be a country that has a very little Gini factor compared to other countries. However, so it seemed that health disparities were small, relatively small in Japan. That was the understanding. However, now the wealth gap is prevalent in Japan. So we are actually a country that has income disparity as well as poor children amongst the developing country. So moving forward, I believe this health disparity or health gap will widen in Japan.
Very much. Dr. Holman, do you have any comments about Professor Kondo's answer?
That's really interesting to hear. Thank you. Yeah, I guess it's just, it makes me think that there's always this challenge, isn't there, that health inequalities probably mostly reflect social inequalities. And you said the health gap is increasing. So it's really challenging to think what we can do against that tide of widening inequality. It's a massive challenge, and if the wealth gap is increasing, then it requires some creative thinking on how to address inequalities within that context. Thank you.
Thank you. So probably this, I have a second question, but this Professor Kondo partly answered this for the next question. But in Japan, how the inequalities have changed or changing over time? Are they widening or staying the same? So Professor Kondo, do you have any comments about this point?
So as I have already answered, in Japan, it sometimes have decreased, but we need to monitor. What is necessary is to monitor this trend.
On to the next question. So Dr. Holman asked about the relationship between socioeconomic factors and social capital. Are people likely to participate in different types of sports or activities depending on their socioeconomic status? And what implications does this have for their health and well-being? Professor Kondo, please.
According to my research, it really depends on what kind of sports activities you involve. Some of the activities draw more participation from those with a lower socioeconomic background. There are actually different kind of activities with lower participation and with lower social economic status. So the sports and the volunteers activities, like higher income people would be more encouraged to involve such activities. But when it comes to the community-based activities nearby the place where they reside, the tendency is actually the reverse, not only in the Taketoyo project, but also the 64 municipalities across the nation actually showing the same result. And actually it's the 47 out of the 64 shows the same result. So overall, that's the tendency. However, even the community-led activities depends on how we organize. 60 municipalities have higher participation with the higher income people. So we need to avoid any activities widening the health inequality, but rather would focus on those who can reduce the inequality.
Dr. Holman, do you have any comments about this answer?
Yeah, no, so I couldn't agree more with the last point. So often, there's lots of evidence to show that when we implement a well-meaning interventional policy without attention to inequalities, inadvertently, we can increase them. And from a public health perspective, that's absolutely not what we want to do. So I agree with that point completely. And just in relation to these activities kind of being based in particular communities, I think that's a powerful approach in the sense that people that tend to live in the same place have something in common. So it's a way for people to bond and to increase participation and for people to feel comfortable in joining those activities.
Mm-hmm. Yes, yes, thank you very much. And we would like to keep learning about this topic, but unfortunately the time is running out. And we have received a lot of questions from the audience, but we apologize for not having enough time to share those questions and have Professor Kondo and Dr. Holman to answer. So so I have to wrap up the discussion, but as the last question, I would like to ask you two. So from today's lectures, comments and discussion, we understand very well that in order to reduce health gap in a society, national and the local governments need to implement policies to change the environment in various levels in our society. So probably some people in the audience are thinking, it's a social problem. It's not, there isn't many things that I can do because I don't make policies and I don't decide how to use taxis. However, I believe that there are things we can do in more local level or even individual level to reduce the health gap. So I would like you to tell us what we can do in our daily life, probably, to reduce health gap. So, Dr. Holman, do you have any thoughts on this?
That is a real challenging question. That's really difficult to answer. Yeah, that's difficult. I mean, I agree with your assertion that this is like a multi-level problem, and I don't think there's any way past that. So, you know, it's not only multi-level, but it's multidisciplinary as well. So thinking from, you know, an academic perspective, I think that healthy aging, health inequalities, these topics must involve different disciplines, and there needs to be much more of that. So people still tend to work in their silos, and we're only going to tackle a problem like this by bringing together different disciplines. In terms of what individuals can do, I mean, obviously people can kind of try and take care of their own lives, but they can only ever do that in the context in which they live. So for me, you can't get away from the importance of those social determinants, the living, the working conditions, the green space, you know, all these things are absolutely fundamental. So as a sociologist, I'm struggling with the individual level. Maybe Professor Kondo has some ideas on that.
Thank you very much, Dr. Holman. Professor
Okay.
It's really challenging to answer to that question, and given the time, maybe I would encourage you to read this book. This book actually would tell you what you can do as an individual and what you can do in a community and what the government should do at the national level, like a multi-layer level of the implementation and accomplishment that they can pursue are actually laid out in this book. So I would like to encourage you to read it.
Thank you very much, Professor Kondo. I have read this book and it's very easy to read, even for those people who are not specialized in this area. So I highly recommend people to read this book. Thank you very much. So Dr. Toria, I will get back to you.
Thank you. Thank you, Professor Kondo, Dr. Holman, and Dr. Oda. It's almost a closing time. Today, we had an interesting discussion about health inequality from a variety of perspectives. Although the concept of health inequality may not be very widespread in Japan in general, it is a very important issue, because the economic disparity is a growing problem in Japan, as Dr. Kondo mentioned. I think we need to get closer to this issue and take it more seriously. Thanks to both of you. I'm very pleased to be able to address this important topic at this symposium. We would like to thank Professor Kondo for very informative and interesting lectures, and also Dr. Holman for elaborating on Professor Kondo's presentation and providing insights from outside Japan. We also would like to thank all the audience for joining us. We are going to send a questionnaire to the audience by email, and in chat, you can also access the questionnaire. Please see the chat box, and so we would be grateful if you could take a moment to give us some feedback. Well, this symposium is now closed. Thank you and have a good night. Thank you.